Hi, everyone. Good afternoon. Welcome to the webinar today, Orientation to Agricultural Worker Health. I'm going to first start by covering the learning objectives we'll be discussing today. Our hope is that by the end of this session, you'll have a foundational understanding of agricultural worker health and those unique factors that impact this special population and their access to care. So first, by the end of the session, you'll be able to understand how a migrant health program functions and is funded and the services that they provide to the ag worker population. You'll be able to associate the relationship between the demographics and culture of the agricultural worker population and the impact those things have on healthcare access. And you'll also learn about NCFH agricultural worker specific tools and resources. So for those of you who may not be familiar with NCFH, we are a private nonprofit organization located outside of Austin in Buda, Texas. And our mission is to improve the health and well-being of farm worker families. And we do this by providing programs, trainings, and technical assistance and resources. And we currently serve the 175 community and migrant health centers in our network who provide primary care services to agricultural worker families. And one of the ways that we address our mission is through the Ag Worker Access Campaign. The Ag Worker Access Campaign was launched in 2015 as a joint effort between the National Center for Farm Worker Health, NCFH, and the National Association of Community Health Centers, or NAC. We, along with health center staff and other ag worker advocates, knew that more could be done to increase access to quality healthcare for agricultural workers and their family members. So the result was the Ag Worker Access Campaign. We've seen steady increases over time in the number of ag workers served in health centers since the campaign launched in 2015. In 2021, we surpassed our halfway milestone of 1 million ag workers served in health centers. But unfortunately, in 2022, the UDS data saw a decline. We're confident in the hard work and determination of health centers across the country that we will continue to grow towards our goal, but we need your help. So if you're interested in learning more about the campaign or signing up to join the campaign, please check out the link in the chat to sign up and learn more about this important initiative. So to start today, in order to understand the Migrant Health Program, when and why it began, we're going to take a look back at the history that led to this program. So the US has imported agricultural workers for a very, very long time. Since the nation's creation, agriculture and the small family farmer have been considered essential components of our society. Starting in the 1850s, there were major advances in crop production. Crop production continued to grow larger and larger. And as crop production grew, wars happening throughout the world that our country was involved in caused labor shortages to work the fields. The demand for immigrant labor continued to grow into 1917 when the US entered World War I. In response, Congress passed the Immigration and Nationality Act of 1917. This established the legal basis for the importation of 70,000 workers from Mexico, and this was the first guest worker program in the US to date. Then again, when the US entered World War II, commercial farmers faced a high demand for their products without sufficient labor. And the US called on Mexico again to fill this labor void through the establishment of the Bracero Act. This was the largest guest worker program to date. Although the Bracero Act was devised to meet the World War II labor shortages, the program continued until 1964, ultimately employing about 5 million Mexican laborers. In 1952, the H-2 program was established. This program is very similar to the Bracero Act, but requires certification of labor shortage by employers to legally import workers. And this program is still in existence today as the H-2A program. By 1962, many agricultural workers were in the fields were experiencing harsh conditions, low pay, and little access to care. So President John F. Kennedy signed the Migrant Health Act, also known as the Public Health Act, Section 329, which authorized funding to create a small number of migrant health centers to provide preventative and primary healthcare services to the agricultural worker population. Initially, the Migrant Health Center served only agricultural workers and therefore only operated during agricultural seasons. This created a feeling of community sentiment or preferential treatment to agricultural workers within the communities where these migrant health centers were located. And thus, community members expressed interest in wanting access to these health centers as well. In response, the federal government made money available to these migrant health centers already receiving migrant dollars to jointly serve the community under Section 330 of the Public Health Services Act. This meant that health centers receiving federal assistance under Sections 329 and 330 were under obligation to provide services to both migratory agricultural workers and the community as a whole. Although some health centers have done an excellent job in maintaining focus on serving both populations, others have felt overwhelmed and challenged to maintain that same level of focus in reaching the agricultural worker community. This problem is further aggravated by the limited resources available to provide outreach, translation, transportation, and other enabling services that are really essential in serving this hard to reach agricultural worker population. So in 1996, Congress approved the Health Center Consolidation Act, which authorized the consolidation of migrant, Section 329, community, Section 330, and homeless, Section 340 sections of the Public Health Act to be all under the umbrella of 330 programs. Under this consolidation, migrant health money was integrated into the community health funding and then expanded its reach to also provide services to aged and disabled agricultural workers. So Section 330 of the Public Health Services Act is defined as the Health Center Program, which is a funding opportunity for organizations to provide healthcare services to underserved populations. So from this Consolidation Act that I mentioned at the tail end of that history overview, definitions were created for health center programs to define agriculture and the three classifications of agricultural workers. As defined in legislation, agriculture means farming in all of its branches. This includes cultivation and tillage of soil, the production, cultivation, growing, and harvesting of any commodity, and includes any practice, including preparation and processing for market and delivery to storage or to market or to carriers for transportation to market. As I mentioned, the legislation also created definitions for the three classifications of agricultural workers for the Migrant Health Program. This includes migratory agricultural workers, seasonal agricultural workers, and aged and disabled former migratory agricultural workers. And these definitions become important to understand for the identification and reporting of agricultural worker patients in your Uniform Data System reporting or your UDS reporting. Our upcoming IAC webinars in November will discuss this topic, and registration information for this topic will be shared later in the session. A great way to understand the ag worker population is to take a look at the most recent demographic data on this population. Data on agricultural workers that we'll be sharing today comes from the National Agricultural Workers Survey, or the NAWS survey. And this survey collects data related to demographics, employment, and health characteristics. This survey is conducted annually, and results are not published every year, but the data we'll be sharing today is from the 2019-2020 survey. And in the chat, there is a link to a fact sheet that NCFH has developed to summarize some of the key statistics of this survey. So to start, we're going to look at some very general demographic information. The average agricultural worker is 41 years old, with roughly 67% falling between ages 25 and 54 years old. 1/3 of agricultural workers are younger than 35. Looking at gender, 66% are male and 34% are female. 77% of ag workers identify as Hispanic, and among US-born workers, 30% self-identify as Hispanic. More than half of agricultural workers are married at 57%, and half of ag workers are parents. Looking at some other key demographic information, 20% of agricultural workers earn below the poverty line, which is an annual income of less than $30,000. When it comes to education, the average educational attainment is ninth grade. 35% of agricultural workers report completing sixth grade or lower, and only 12% have completed some education beyond high school. Looking at language, Spanish and English are the primary spoken languages within this population. 62% of agricultural workers report preferring Spanish as their speaking language, and 27% prefer English. Among workers born in Mexico or Central America, nearly all reported that Spanish was their primary language at 93%. And although Spanish and English are the primary languages for this population, we know that there are other languages spoken among agricultural workers, including indigenous languages and Haitian Creole. Looking at healthcare utilization, 71% of agricultural workers used healthcare services in the US in the past 2 years. When it comes to payment, 26% paid for their services out of pocket, 16% paid using personal or family insurance plans, 24% used Medicaid or Medicare, and 11% were not charged for their visit. When it comes to employment, we know agricultural work is not steady. It's very dependent on season, weather, and market demands. Year-round work is not always possible due to the nature of agriculture. Agricultural workers are typically employed by growers or packing firms directly at about 89%, with a small percentage employed by labor contractors, about 11%. Looking at working hours, workers' hours accommodate the crops, not vice versa. So there are different payment methods that agricultural workers receive. 42% of agricultural workers report working more than 8 hours a day. And on average, workers work 35 weeks of the year in agriculture, 6 weeks doing non-agricultural work, and 9 weeks unemployed while in the US, and an average of 2 weeks per year spent outside of the US. Looking at migration patterns, 13% of ag workers are migratory and 85% of ag workers are seasonal. And of those migratory workers, 47% were domestic and 42% were international, and 11% had been in the US for less than a year. Looking at work type, 28% reported working in fruits and nuts, 20% work in vegetables, and 24% work in horticulture. Looking at housing, 30% of ag workers reported living in a crowded housing situation where more than one worker shared the same room, and 14% live on the farm of their current employer. The graphic on this slide shows traditional patterns of mobility among agricultural workers. There are 3 traditional main streams of migration, as you can see on this map. They are the Western, Midwestern, and Eastern. California, Texas, and Florida are very common starting spots of migration within their designated streams, sometimes moving across the United States in many different directions. It is estimated that we now have about 10 to 13% of the agriculture workforce migrating internationally because of the H-2A program. And approximately 13% of crop workers are H-2A workers. Next, we're going to transition into talking a little bit about working and housing conditions and how they impact agricultural workers, their health, and their barriers to accessing care. So looking at working conditions, as I mentioned before, availability of work depends on season, weather, and market demands. Hours can be extended from very early morning to very late in the evening and done every day versus a typical 5 days a week. Income can be paid by the hour, by the piece picked, and some receive salaries. The majority of agricultural workers do not receive benefits. 86% of ag worker households reported not receiving a benefit of a needs-based program in the past 2 years. Adequate, affordable, and safe housing has been and continues to be a constant struggle for migratory and seasonal agricultural workers. A small 14% of agricultural workers may have housing provided by their employer, and this is often the case for migrating workers, given that they travel for work, and this need is traditionally met by growers creating labor camps. Employers recognize that the lack of housing is a serious problem, but they face several disincentives to providing housing for migratory agricultural workers. Given that construction and maintenance of these housing camps is often expensive, especially if housing will only be occupied during a short harvest season. Due to these factors, housing is often substandard. However, most agricultural workers do not have housing provided by their employers and often need to find their own housing. Nationally, 50% of workers report renting property for housing. However, most communities may not have enough rental units available, or they may be unavailable to agricultural workers because they cannot provide deposits, qualified and credit checks, or make long-term rental commitments due to the nature of their seasonal or migrating work. Therefore, agricultural workers struggle to find places to live, especially in rural areas where housing is already very limited. Some end up sharing rental properties with others who work at the same farm to help make it more affordable. However, much of the housing available for rental is deficient, crowded, and unsanitary, which can add to health risks. Some agricultural workers report owning their own private housing at roughly 35%. This is often the case for seasonal agricultural workers. Private housing is not subject to federal regulation. Therefore, whatever is available to agricultural workers tends to be substandard and many times very expensive. We often see workers living together under these conditions as well, especially with families and relatives. Again, this makes it difficult to practice sanitary housing conditions and also difficult for quarantining and practicing physical distancing recommendations, as we've seen throughout COVID-19. In the absence of housing, agricultural workers may be forced to sleep in tents, cars, ditches, or open fields. As mentioned, much of the housing available to agricultural workers is deficient, crowded, and can have sanitation issues, so this can add to health risks. Some of the common illnesses related to housing that we often see are UTIs and intestinal parasites, skin conditions, respiratory conditions, and infectious diseases. The crowded housing makes it difficult to practice those social distancing recommendations that we've seen become incredibly important in the prevention of COVID-19, as well as other infectious diseases such as flu. So now that we've discussed the conditions related to work and housing, we're going to discuss the risks associated with agriculture as an occupation, as well as some of the environmental risks involved in this work and what regulations or lack of are in place to protect agricultural workers. Immigrant workers are often vulnerable to labor trafficking, where an employer may control the movement of their workers through threats, physical abuse, debt bondage, or other means. Agriculture had the second highest number of reported labor trafficking cases in the US in 2015. Agricultural work is consistently ranked as one of the top 3 most dangerous jobs in our country. And in 2020, about 368 agricultural workers died of work-related injuries. Many of the occupational risk injuries that workers face are related to the specific type of work that they do. Some of these issues can be musculoskeletal injuries and disorders, such as carpal tunnel, shoulder pain, sprains and strains, low back pain. The repetitive motions and heavy lifting involved in agricultural work can cause pain, arthritis, and other health problems. Agricultural workers often perform repetitive movements that can contribute to these ailments, such as stooping, picking, carrying, lifting, equipment work, packing, reaching, and even falls from ladders or other equipment. Other risks relate to the way agricultural worker is set up in general. Due to being outside all day, weather plays a very big role and can contribute to heat stress and dehydration. Agricultural workers are also at risk of insect, rodent, and snake bites. The practice of piece rate wages versus hourly wages also encourages agricultural workers to work longer, harder, and faster without taking breaks in order to earn more income. So beyond the expected physical impact of this practice contributes to agricultural workers not taking the time that they need to take care of themselves while working. For example, not attending medical appointments or managing chronic health conditions due to wanting to not stop working so they can continue earning more income. Additionally, vehicle accidents are a large problem amongst this population. Workers are often transported to and from work by their crew leaders in unsafe and crowded vehicles that may not have safety precautions such as seatbelts. In addition, because agricultural workers may migrate, the opportunity for accidents on the road is greater for agricultural workers compared to the general population. And as we saw throughout the COVID-19 pandemic, the lack of safety precautions implemented in the workplace, such as lack of 6-foot social distancing, lack of personal protective equipment, lack of hand washing stations, and the inability to take time off work to quarantine added additional occupational risks. This slide highlights some of the problems associated with field sanitation, pesticide exposure, and the environmental risks associated with agricultural work. Agricultural work, as we mentioned, requires lots of different labor, stooping, climbing, carrying heavy loads, and working directly with soil and direct contact with plants. This direct contact with plants puts agricultural workers at risk of exposure to pesticides and chemical fertilizers that are used in cultivating the plants. Some plants, such as tobacco and strawberries, release chemicals that can be toxic to humans and can cause severe allergic reactions, such as contact dermatitis. In addition, there are anecdotal reports of workers resorting to irrigation ditches or runoff ponds when safe water is not available for hand washing or drinking. Pesticides and chemical fertilizers and organic wastes contaminate this water and can lead to illnesses, including conjunctivitis, intestinal illness, cancer risks, among other things that are very dangerous. These disorders and conditions can be misdiagnosed given that they have common symptoms. So it's really important for health centers and health center staff to understand the risks and environmental risks at play for agricultural workers so that they can be correctly diagnosed. The EPA estimates between 10,000 and 20,000 poisoned agricultural workers per year. Exposure to pesticides and chemicals can additionally put family members of agricultural workers at risk from the residue that is left on tools, clothing, shoes, and skin. To address some of the occupational and environmental risks that we've mentioned, there are 3 main regulations that have been put into place specifically for agricultural workers. The first is the Department of Labor created the Migrant and Seasonal Agricultural Worker Protection Act in 1983. This act established the rights of agricultural workers and the guidelines that labor contractors must follow. The second is from OSHA, the Field Sanitation Standard of 1987. This applies in all states and requires the availability of potable water and sanitary toilet facilities. OSHA has put regulations into place that require agricultural employers of 11 or more workers to provide drinking water, hand washing facilities, and toilets for their employees. However, farms with 10 or fewer employees are exempt from these requirements. The intention of this exemption was to avoid placing a financial burden on small farms. However, as a result, these very basic amenities are not required by their work in the fields. Third is the Environmental Protection Agency, the Worker Protection Standard of 1992. Federal regulation designed This federal regulation was designed to reduce pesticide poisoning by requiring safety training, notification of when pesticide is applied, and the use of personal protective equipment, as well as restricting entry and exit after pesticide application, providing decontamination supplies, and having emergency medical assistance. It is important to remember that the enforcement of these regulations is dependent on the size of the farm and the entity in charge of enforcement in the area. And as you can tell by some of the dates included on this slide, big federal regulations to protect agricultural workers have not been created or updated in over 30 years. So there are a few labor rights that agricultural workers are excluded from. One being the right to organize and bargain collectively under the National Labor Relations Act. They're also not entitled to overtime pay under the Fair Labor Standards Act, with the exception of California, which was able to put this into place for their agricultural workers in 2016. And agricultural workers are only covered by 7 Occupational Safety and Health Administration, or OSHA, standards. There have been some improvements in some states, as I mentioned, for example, in California in 2016, expanding the regulations to entitle agricultural workers to better overtime pay. They were the first and only state to grant overtime pay to agricultural workers. California also signed a landmark agreement that gave ag workers the right to organize. However, this is not the case in many other states. So this means that agricultural workers have less protections than many other labor groups and are at a greater risk of illegal or unfair treatment, injuries and unhealthy conditions, scams, and many other risks. So we're now going to transition over to my colleague Lisa to talk about medical conditions and barriers to care.
Thank you, Katie. So now that we have an understanding of the general characteristics of the population, the housing and employment conditions, and some of the protections and lack of protections that ag workers receive, let's talk about the medical conditions that are commonly experienced by this population, as well as their barriers to accessing healthcare. Research indicates that agricultural workers have lower rates of many chronic diseases compared to the general population, but a lack of access to health care may mean that many have undiagnosed health conditions. So that may not exactly be accurate data there. Common chronic conditions include those seen on your screen there, including diabetes, obesity, hypertension, as well as chronic respiratory and musculoskeletal disorders that Katie mentioned earlier in this presentation. And the primary challenge for an agricultural worker patient with a chronic disease, especially one who migrates, is continuity of care and self-management. Oral health has been ranked as one of the major health problems facing migratory and seasonal agricultural workers, as well as one of the unmet needs in healthcare services for this population. Migrant children are more likely to have decayed tooth surfaces than non-migrant U.S. school children, and many adult migratory and seasonal ag workers do not seek oral health care unless it's an emergency. So high rates of decayed tooth surfaces, not seeking treatment, and poor oral hygiene leave Latino migrant workers and their families particularly susceptible to poor oral health. This is important because, as stated on this slide, poor oral health reduces quality of life and is related to chronic conditions such as stroke, heart and lung disease, and diabetes. And then mental health conditions. Mental health is also a concern among agricultural workers. So conditions sometimes associated with high levels of stress include anxiety, depression, substance abuse, domestic violence, and post-traumatic stress disorder. And this is in particular impacts ag workers, and the mental health of ag workers, because of some of the unique situations they face, like traveling alone, family separation, lack of family support, lack of adequate childcare, lack of adequate education and nutrition programs for children, and food insecurity. So all these things just make those stressors even worse. And another thing to keep in mind with this population in particular is that ag workers may be reluctant to talk about mental health issues due to cultural barriers and stigma within this population. And this slide talks about the barriers that ag workers face related to accessing healthcare on an individual level. So mobility and long days often threaten ag workers' health and pose a significant barrier to them accessing healthcare. And we mentioned previously about their limited income. As previously stated, many ag workers have total family incomes below the federal poverty level. So this puts a worker in the predicament of having to choose between paying for healthcare and meeting their essential needs. Many workers also do not have health insurance, which forces them to seek medical care only when it's absolutely necessary, and preventive care may not be a priority for them. Also, because of limited benefits that workers receive, sick leave is rarely an option. So oftentimes, ag workers will not take time off from work to take care of their healthcare needs due to fear of losing their jobs. Additionally, one of the most commonly reported barriers is language. An estimated 65% of workers cited Spanish as their native language, and therefore their inability to speak English fluently or comfortably can pose a great barrier in their health care. And many workers additionally have low levels of literacy, even in Spanish. So this is really important as we think about development of materials, patient educational materials for our patients, being aware of their language of preference and how they can best understand information they're receiving, so making sure it's in the proper language and the proper literacy level. The culture of workers often gets in the way of accessing medical care as well. For example, workers may rely on homeopathic remedies handed down from generation to generation to treat their ailments. So therefore, they may put off seeking medical care until it's too late. And workers are often unfamiliar with the U.S. healthcare system and therefore don't seek existing services or have knowledge to navigate the healthcare system effectively in order to meet their needs. And then, of course, lack of transportation, as Katie mentioned earlier, is a major barrier to care, especially for those ag workers living in rural areas or working in rural areas where mass transit is not available. And then looking at a systems level, labor policies that include lack of paid sick time and regular time off are barriers to care. Community and workplace barriers exist for this population. Limited healthcare sites, especially when they're working in remote locations. Immigration systems and threat of deportation are also a barrier to care. Exclusion from public and private health insurance. And then lack of awareness about the challenges faced by the ag worker population by public health officials and healthcare providers is a major barrier. So that's why this information shared in these webinars is really important to share within your health center to make sure that providers are aware of these barriers and they're able to address them. So how are health care services delivered to the ag worker population? Let's talk about migrant health service delivery. So as Katie mentioned earlier, grantees receive federal funding from PHS Section 330 to provide services for people in the community, and 330G specifically for the migratory and seasonal ag worker population. Although the size and extent of services varies by center, the majority do provide comprehensive care within their networks, although it's not uncommon to have health centers offer the basic on-site services and then refer a patient to a larger clinic within their network for additional services that are needed. And as a rule, the larger the budget, the more comprehensive services a health center can offer. But at a minimum, the services listed here on your screen are the wide range of diagnostic and support services that the federal government requires. So they include primary care services, which is treatment of infections, chronic disease, and general problems, preventive services, including immunizations and health screenings, emergency services for accidents, injuries, and sudden illnesses, and pharmacy services on location. Most health centers do offer on location pharmacy services, as well as ancillary services. And outreach and enabling services are important. In fact, they're critical, especially for the migratory and seasonal ag worker population, because they do help increase access to care for this population. So as we discussed earlier, ag workers face many challenges in accessing primary healthcare services due to the hours they work, lack of transportation, and all the other barriers that we shared. So these are the services that health centers can provide to help ensure ag worker families have access to these primary healthcare services and also facilitate access to comprehensive health and social services. So they include case management, coordination of care, patient and community education, outreach, eligibility assistance, transportation, and interpretation and translation services. So in the chat, I'd like to, if you have, we'd like to know what some of the outreach and enabling services are that your health center currently offers and what's successful for you all. So we're always looking for promising practices, and this is one of the areas that we really want to gather information about. So if you have any promising practices that are successful for your health center or your organization, please drop them in the chat, and then we'll discuss them during the Q&A time after this session. And also, if there are any areas that you're having challenges with, please list those in the chat as well, and we'll add those to our discussion at the end of this session. And we recognize that there are service delivery challenges and other systems barriers that can stand in the way of providing these great outreach and enabling services. So there are three main organizational systems that can lead to overcoming these barriers and are essential to have in place within your organization. And they include policies, procedures, and training. So one of the things that we work with health centers on is migrant health action planning. And we'll talk about that in a couple of slides, but that's one way that we can look at these systems strategically and set some goals. And we can help you with that. So we'll talk about that in just a moment. But there are many things to consider when addressing these organizational systems. Some things to think about are your hours of operation, and do they meet what the needs are for the ag worker population? Do you need more capacity? How long are your wait times in your health center? What's your training protocol for your staff? And do you have continuing education available for staff around culture, language, customer service, all those things that are essential to help your special populations? And as we mentioned previously, continuity of care is one of the biggest challenges in ensuring quality health care for ag workers, mainly because of the mobility of the population. So even when an ag worker returns to the same area year after year, continuity of care and managing these conditions can be difficult. Changes in geographic location may occur multiple times a year, which disrupts chronic disease management and conditions like diabetes. So what we often see is ag workers seeking care, as we mentioned before, only when absolutely necessary, or they may begin treatment but can't continue because it's time to move again. So when they seek care in the new community, they may not remember the names of their medications they were prescribed, the dosages, or even their diagnosis sometimes. So all these things come into play, and we need to think about that and how we can help with that as our ag worker population migrates. So one of the things we can consider is case management, because we know that proper case management can help prevent the disruption of chronic disease management and can prevent misdiagnoses that may occur at the new location and even reduce the chance that a patient might over-medicate. Self-management is key in controlling chronic illnesses, so it's important to educate our patients in order to help them understand what they need to do to self-manage their illness and what information and records they need to take with them when they travel to help set the stage for the best possible outcomes. So we'll keep moving forward with the presentation, but I do invite you to also share in the chat here any strategies you have in place to ensure continuity of care for your ag worker population, and we can discuss that at the end of the session. So our Increased Access to Care for Ag Workers program and the associated trainings were launched in collaboration with the Ag Worker Access campaign that Katie mentioned at the beginning of the session, to assist health center staff in accurately identifying and reporting their ag worker patients in the UDS. Since then, the program has grown to include a national virtual network comprised of health center controlled networks, and primary care associations that are all working together toward the mutual goal of increasing access to care for ag workers and their families. So the network members participate in our Increased Access to Care Learning Collaborative. They participate in Ag ID registration quarterly huddles, which really helps you to practice those steps for proper identification, classification, and reporting of your ag worker population in UDS. They participate in virtual learning sessions. They participate in migrant health action planning, like I mentioned earlier. So really kind of looking at your migrant health program and identifying any gaps and then setting goals to alleviate those gaps. And we can help with that. So that's another thing that this program does. The program members also share their UDS information with us twice a year to monitor outcomes. And then they share knowledge, tools, and resources with each other. So it's really all about peer-to-peer exchange of strategies. So we talk about challenges and then strategies to alleviate those challenges. So we do encourage you to join our network and participate in these activities. And then we also encourage you to join the Ag Worker Access campaign. If you haven't already signed up to be a part of this initiative, we invite you to join the campaign. So you can join as an individual member, or you can join as an organization. And when you join the campaign, you'll receive tools, resources, and opportunities for your health center to organize yourself to support increasing access to care for ag workers and their families in your community. You'll also receive promotional materials you can use on your website and social media, and other information to get more involved in the campaign. So we do encourage you to follow the link shared in chat and learn more about the campaign and become a member. And then this is the end of our presentation. For those of you who are joining us live, please stay on and we'll continue on with our live Q&A. For those of you watching the recording, this concludes today's session. Thank you all so much for joining us.